Bismillahirrahmanirrahim. Assalamu alaikum you all. Welcome back in our second session with the distant learning, virtual learning program, virtual learning session. I'm Dr. Shahid Mehmood and I'm going to discuss with you advanced trauma life support and the primary survey. Before going into the detail of this lecture and the discussion and starting, I just want to explain you, or I just want to tell you the brief historical background in development of this ATLS program. A couple of decades ago, in 1976, an orthopedic surgeon, he was piloting his plane in the rural Nebraska cornfield. There he got crashed his plane. His wife died at the scene. He got serious injury along with his three children. They also got serious injuries. One child got minor injuries, and the treatment they received in that rural area, he was very disappointed in having that treatment. And at that spot, at that scene, he said that when I can provide better care in the field with limited resources than what my children and I received at the primary care facility, there's something wrong with the system, and the system has to be changed. So he, along with his colleagues, they made untiring efforts. They did meetings, and then they developed a standard program, that is advanced trauma life support program, in managing the trauma patient in a standard way that is now being followed almost in every country. And so now we start this ATLS and primary survey. So first we describe the definition of trauma. This trauma definition, this word basically originates from the Greek word meaning wound, and it implies that physical force exerted on a person leading to a physical injury. And this injury can be in different forms. It can be thermal injury, it can be chemical injury, ionizing radiation, and most frequently all these are mechanical origin. And amongst all these, trauma remains the most common cause of the death and disability in the children and young adults in resource-rich countries. If we go into the distribution of global injury mortality by the cause, so road traffic accident, that is 23%, remains the highest percentage of the cause of mortality in trauma patients or in global injury mortality. And again, with the immediate pattern, if we go in trimodal death pattern in trauma patients, so we have some early deaths, late deaths, and immediate deaths, that we also describe them in the first peak, second peak, and third peak. So this trimodal death pattern, this was first described in 1982, and this is basically trimodal distribution of the death, and implies that death due to the injury this occur in one of the three phases or in three periods or peaks. So the first peak, it is known as also immediate cause of the death. It is this happened within seconds to the minutes of the injury. Most common causes amongst the cause is the apnea, and apnea due to severe brain injury, high spinal cord injury, or rupture of the heart, great vessels, or the aorta. And only prevention can significantly reduce this peak of trauma-related death. Then comes the second peak. Second peak is the early cause of the death. This occurs within minutes to the several hours following the injuries. And the death is usually due to the subdural and epidural hematomas, pneumothorax, ruptured spleen, laceration of the liver, pelvic fractures, or other multiple injuries associated with significant blood loss. And then comes the third peak, that is late deaths. This occurs several hours, several days to the weeks after injury, and most common causes are the sepsis, multiple organ dysfunction. So this is the trimodal death distribution in trauma. So if a patient with trauma, when we got the patient with the trauma in a trauma center or in a tertiary care hospital or in any hospital, so there must be some initial assessment, and it includes the following elements, that is the preparation at the hospital, preparation at the trauma scene, then triaging of the patients, then primary survey ABCD, that is airway, breathing, circulation, disability and exposure, with immediate resuscitation of patient with life-threatening injuries, then some adjuncts to the primary survey and resuscitation. Then after this primary survey, if there's a need of the patient transfers, we have to consider that. Then secondary survey, that is head to toe evaluation, patient history, some adjuncts to the secondary survey, then continued this post resuscitation monitoring, then re-evaluation, and at last the definite care. So regarding the preparation of the trauma patient, this happened in two phases, in two clinical settings, that is pre-hospital phase, that is in the field area at the trauma scene, and then hospital, in the hospital. Pre-hospital phase, basically the main emphasis for a trauma care provider at the pre-hospital phase is airway maintenance, and if there is any external bleeding, so control of the external bleeding, control of the shock, resuscitation of the patient, immobilization, and immediate transfer to the appropriate verified trauma center. So pre-hospital provider, he must make every effort to minimize scene of the trauma, scene time, to minimize the time. And during this phase, pre-hospital phase, the events, they are coordinated with the clinician at the receiving hospital. So in doing this field triage, there are certain steps which has to be followed, and this includes step 1, step 2, step 3 and step 4. And the first two steps are very important in managing, and if there's any patient that lies in between these two, he should be immediately referred to a proper trauma care centers. That includes, in the first step, if GCS, that is Glasgow Coma Scale, is less than 13, systolic blood pressure is less than 90, respiratory rate is less than 10 or more than 29 breaths per minute, or there is need of ventilatory support. If all these above are present, then patient should be referred to a verified trauma care hospital, trauma care center. And if all these are not present, then assess anatomy of the injury, then all the penetrating injuries to the head, neck, torso, then two or more proximal long bone fractures, crushed injury, degloved, mangled or pulseless extremities, amputation proximal to the wrist or ankle, open or depressed skull fracture, paralysis. If all these are present, again transport to the closest appropriate trauma center should be done. And if these are not present, then assess the mechanism of injury and evidence of high impact, like in falls. If adults, they have more than 20 feet history of fall, that is almost 2-story building, and in children more than 10 feet or 2 to 3 times the height of the child. Then high risk auto crash history is there, motorcycle crash. If all these are present, then patient should be transported to a trauma center or hospital capable of evaluating and managing this patient. And if this is not present, then we have to assess the special patient or system considerations, like older patients, and in children, if the patients, they are on anticoagulation and they are having bleeding disorders, burns, pregnancy more than 2 weeks. If all these are present, then they should be transported to a trauma center or hospital that is capable of managing this patient, and if not, then transport according to the protocol. And in hospital phase, there should be advanced planning for the arrival of trauma patient. That is very essential. The handover between the pre-hospital providers and those at the receiving hospital, they should have a smooth process directed by trauma team leader. He should be there to organize everything, ensuring that all important information is available to the entire team. So in hospital phase, there are some pre-alert checklist, that introduction to the trauma team, and the key role should be assigned, that who is going to do what duty, who is going, and then protective equipment should be worn by the team. Then equipment should be checked like airway, warm fluids. If the patient needs some scanning, then a CT scan radiology department should be notified. Blood banks should be informed that a trauma patient is coming and he may need blood transfusions. Trauma team should be activated. Pediatric calculations should be completed as required, and appropriate monitoring should be immediately available. Triage. It's very important. This basically includes sorting of the patient based on the resources required for the treatment and resources that are actually available. So we have to sort out the patients, that which hospital or which facilities that contains the ability or contains resources that should not, you can say that patients should not increase to the resources of the facility. So we have two categories in this: multiple casualties and mass casualties. And if the patients are coming with in multiple casualties, this means that multiple casualty incidents, they are those in which number of patients and severity of their injuries do not exceed the capability of the facility to render care. So means that the hospital has sufficient resources in managing these patients. And in such cases, patients with life-threatening problems and those sustaining multiple system injuries, they should be treated first. And in mass casualty, the number of patients and the severity of their injuries, this does exceed the capability of facility and the staff. Or in such cases, patients having greatest chances of survival and requiring the least expenditure of time, equipment, supplies, and personnel, they should be treated first. So now we come to the point with the primary survey and simultaneous resuscitation. Patients at the trauma scene, they should be assessed, and their treatment priorities should be established based on the injury, vital signs, and injury mechanisms. This primary survey, this includes A, B, C, D, E. That is airway maintenance with cervical spine support, breathing and ventilation, circulation and control of hemorrhage, disability, that is assessment of neurological status, and exposure, that is environmental control. So there's a question: how can we assess A, B, C, D with a single question? That we are going to assess that patient airway is maintained, his breathing is adequate, there's no hemorrhage, his circulation is okay, he's not in shock, and there's no disability. Only one question, that is ask the name. Ask the name of the patient. If the patient can tell you his name, means A, B, C, D is intact. So accentuating external hemorrhage. If a trauma patient is having accentuating external hemorrhage due to the massive arterial bleeding, this needs to be controlled even before the airway. And this should be controlled immediately by application of packs and pressure directly over the bleeding wound and artery. Hemostatic dressings that contain agents that augment local coagulation should be, if available, should be applied, and application of tourniquet proximal to the wound. Do not apply any artery forceps in the bleeding area. Just packing pressure, pack pressure. So the first thing, airway maintenance with restriction of the cervical spine movement. So airway should be assessed for the patency. If the patient able to communicate verbally, well, his airway is intact. Then inspect for any foreign body. If there's any foreign body like broken teeth in the oral cavity. Examine for the stridor, hoarseness, gurgling, pooled secretion, should be aspirated or blood should be aspirated, sectioned out. Then in every trauma patient, you should assume cervical spine injury in patients with multi-system trauma. So this cervical spine clearance should be done both clinically and radiologically. C-collars should remain in place until the patient can cooperate with the clinical exam. Airway intervention should be done in the form of supplemental oxygen should be provided, suction of the secretion, blood should be done. We can maintain the airway with chin lift, jaw thrust, or we can pass oral or nasal airway. And the definite control of the airway is with RSI for agitated patient, that is rapid sequence intubation, and then endotracheal intubation for comatized patient if they have a GCS less than 8. So this short video is going to discuss with you how to maintain the airway management.
Intubation include being really prepared before you start your attempt. You want to make sure all your equipment is ready to go. We've talked about ensuring that the laryngoscope blade is well lighted, the batteries are fresh. You want to make sure that you have oxygen flowing to your bag device, making sure that your cuff on your mask is inflated. And when you want to have your patient in the best prepared position, by getting them very well oxygenated before you try your attempt. This involves maybe a little hyperventilation so that you can pink them up a little bit, because they're not going to be breathing the whole time that you do your intubation attempt. Likewise, after you've had a successful intubation, you want to make sure that you are in the trachea. And there are several devices that we can use, as well as making sure we visualize the tube going through the cords, make sure that we watch for rise and fall of the chest. We auscultate, and that's 3-point auscultation over the right, left, and over the belly to make sure we don't hear borborygmi there. Then you can use extra devices. One is our end-tidal CO2 device. We want to make sure we see the change from the dark gray into the light sunshiny yellow. Likewise, we can use an esophageal intubation detection device. You place this over the tube, depress, and it should flow and open up easily. If the bulb stays suppressed, then you know you're probably in the esophagus. We also have electronic measures that are useful in verifying that we are successfully in the trachea. We can use pulse oximetry. The nice thing about pulse oximetry is it gives you continuous feedback, so you can monitor as things improve and also let you know if perhaps a tube has been displaced. Additionally, your facility may have the ability to do capnography as well.
So, after maintaining the airway and control of the cervical spine, the next step comes breathing and the ventilation. So airway patency, this alone does not ensure that adequate ventilation is there. And adequate gas exchange, this required maximizing the oxygenation and carbon dioxide elimination. So we should inspect, palpate, and auscultate. We should look for deviated trachea, crepitus, flail chest, sucking chest wound, and absence of the breath sounds. And chest X-ray should be done to evaluate the lung fields. Injuries that significantly impair ventilation in a short term, this include tension pneumothorax, massive pneumothorax, open pneumothorax, and tracheal or bronchial injuries. Simple pneumothorax or simple hemothorax, fractured ribs, flail chest, pulmonary contusions, they can compromise ventilation to a lesser degree, and they are usually identified during the secondary survey. What intervention should be made in obtaining the breathing and ventilation adequate? They should ventilate the patient with 100% oxygen. Needle decompression should be done if there is a tension pneumothorax suspected. Chest intubation should be done for pneumothorax or hemothorax. Then occlusive dressings to the sucking chest wounds should be done. And if intubated, then evaluate the endotracheal tube. Here in this picture, we can see this is the tension pneumothorax. That deviation of you can see the airway to the other side. So here in this video, I'm just going to share with you the needle thoracostomy case of tension pneumothorax.
Needle thoracentesis is the initial treatment of suspected tension pneumothorax. The site used for a needle thoracentesis is the second intercostal space in the mid-clavicular line on the side of the suspected tension pneumothorax. Needle thoracentesis is the initial treatment of suspected tension pneumothorax. The site used for a needle thoracentesis is the second intercostal space in the mid-clavicular line on the side of the suspected tension pneumothorax. An over-the-needle catheter that is at least 2 inches or 5 centimeters in length is inserted into the chest over the top of the third rib into the second intercostal space, puncturing the skin, intercostal muscles, and parietal pleura. A sudden escape of air from the end of the needle both confirms and relieves the tension pneumothorax. The needle is then removed, leaving the plastic catheter in place. If equipment is available, the needle thoracentesis should be followed by prompt placement of a chest tube in the fifth intercostal space of the affected hemothorax as described elsewhere.
So this is the brief review of needle thoracentesis in case of tension pneumothorax. So next comes circulation with the hemorrhage control. Hemorrhage, this is the predominant cause of preventable deaths after the injury. So always suspect if the patient is in shock, there is a bleeding. Hemorrhagic shock, this should be assumed in any hypotensive trauma patients. So rapid assessment should be done in terms of level of consciousness, in skin color, in pulses in the four extremities, and blood pressure and pulse pressure. So cardiac monitoring should be done. Apply pressure to the sites of external hemorrhage. If known obvious external hemorrhage is there, there should be as a two wide large bore IV lines should be established. Central line if indicated. Then if cardiac tamponade suspected, then it needs to be decompressed. Then volume resuscitation if is needed. If already have a blood, then ready if should be transfused. And then level 1 infuser should be available. Foley's catheter to monitor resuscitation should be done. And there's a concept of permissive hypotension, massive blood transfusion, and tranexamic acid in trauma patients. If the patient is severely trauma hypovolemic patient, they should be resuscitated using the blood and blood products with permissive hypotension. Target systolic blood pressure is between 7 to 90 to maintain the supply of the blood to the vital organs and preventing the further bleeding. The only role for the crystallite in initial management of severely hypovolemic patient is only for administration of small quantities to maintain the blood pressure while waiting for the blood products to arrive. Tranexamic acid, this reduces mortality after trauma. Its main role is first hour within few hours of the injury, and all trauma patients with the signs of shock, they should receive tranexamic acid as soon as possible after the injury. And all trauma centers, they should have a massive transfusion protocol. Then in disability is basically neurological evaluation. So there should be a neurological evaluation should be done in terms of level of consciousness, like Glasgow Coma Scale, pupil size and its reactivity should be monitored, should be measured. Then motor function should be assessed, and GCS, this is utilized to determine the severity of injuries and guide for urgency of head CT and intracranial pressure monitoring. So this is the Glasgow Coma Scale that has best eye response, best verbal response, and best motor response. That best eye response contains 0.4, best verbal it contains 5 points, and then best motor contains 6 points. So this should be monitored. Intervention in doing this disability evaluation is if we are suspecting spinal cord injury, then high dose steroids if within 8 hours should be given, intracranial pressure monitoring, and neurosurgical consultation should be done. And the signs of if suspecting elevated intracranial pressure, then head end of the bed should be elevated, mannitol should be given, hyperventilation, and emergency decompression should be done. Exposure and environmental control. It should be done while complete disrobing the patient, and log roll should be done to inspect the patient. Rectal temperature should be taken, warm blankets and external warming devices should be there to prevent hypothermia. This always inspect the back, because the front contains 50% and the back contains 50%. So if we are not inspecting the back in doing the log roll, means we are missing 50% injuries in our trauma patients. Adjunct to the primary trauma, to the primary survey with resuscitation includes continuous ECG monitoring, pulse oximeter, carbon dioxide monitoring, assessment of the ventilatory rate, and ABGs should be done. Foley's catheter should be passed to monitor urine output and also to look for hematuria. Nasogastric tube should be placed, in order to decompress the stomach and also to assess the evidence of any blood in the stomach. X-ray examination like chest X-ray and pelvic X-ray should be done fast, that is the focused abdominal sonography in the trauma, or extended focus assessment with sonography for the trauma, or pan-CT diagnostic peritoneal lavage should be done in trauma patient. So this is the last slide that will show you the whole brief.
Sounds pretty sick. He's an 18-year-old motor vehicle crash victim, unrestrained driver. Sounds like he's a little unstable in the field. Heart rate is in the 120s. Blood pressure is 90/40. He's got an obvious left femur fracture. They have him in a hair traction splint. He's backboard and collared. They have him on some oxygen. It sounds like his O2 sats are in the 88 to 93%, and his GCS is placed.
So minimal responsive, and they've got some oxygen going.
They've
One IV?
One IV, I think 18 in the right AC.
All right. So it sounds like this guy is pretty injured. We're going to need to take care of a lot of things. It sounds like he has an airway problem. It sounds like he's in shock. So a couple quick things we need to do very quickly when he gets here is let's make sure that we got our airway stuff ready to go. It sounds like you need to be intubated. So we got everything we need?
I got everything else.
All right. And Betsy, it sounds like he's only got one IV. So when he arrives, what I'd like you to do is put in second IV in on his other side. If he doesn't have one, we'll get some blood out of that when we do it. Also, if you would call the lab and X-ray before he gets here, make sure they come and help us out. And Tracy, when he gets here also, I'm going to look at his airway, and while I'm doing that, can you put him on a monitor and a blood pressure cuff? And let me know immediately what the vital signs are so we can go from there. And I guess the other thing we want to think about is this guy's probably bleeding a fair amount from the sounds of it, so let's notify the blood bank, and let's get the massive transfusion protocol on standby and make sure that we got that ready to go. Also sounds like this guy is a little too sick for us to keep here. So once we figure out what's going on, let's get the trauma center on the phone because I'd like to talk to him and get him transferred, okay?
Yes, sir.
All right. Any questions?
Nope.
All right, let's do it.
This is Garrett. He's 18 years old. He's an unrestrained driver in a single vehicle MBA into a tree. About 10-minute extrication. He has a GCS of about 8. Has a head injury up here underneath the gauze and has an open femur fracture with some minor bleeding.
Is it motor vehicle collision into a tree?
Yes.
Prolonged extrication.
10 minutes.
He's unrestrained.
Unrestrained.
And you said he's got an obvious head injury
Obvious head injury.
and an obvious femur fracture?
Open femur fracture with some
Okay,
bleeding.
and that's all you see right now?
The bruising to the left chest as well.
And his last set of vitals?
Blood pressure is 90 by pound. He was 120 times tap on the monitor. Respiratory rate was about 12. It's clear bilaterally. And he's unresponsive for us.
Any other issues?
Nothing I know of.
All right, thank you very much.
Thank you.
All right, guys, this guy looks like he's got a lot of injuries, and let's do this in a nice systematic fashion. We'll start with the ABCs. So Tracy, while I'm assessing the airway, I want you to put some leads on. Let's get a blood pressure. And Betsy, if you can come over here on this side and help me with the airway. Looks like he's breathing about 20 times a minute. Sir, can you open your eyes, sir? What's your name? Looks like he's not responsive at the moment. He's got some obvious facial trauma, and it looks like he's not breathing real well. He's a little bit blue.
O2 sat 82%.
O2 sat's 82%, so we're going to need to intubate him. So what I would like you to do, Betsy, is I want you to hold C-spine precautions here. I'm going to take the C-spine collar off.
C-spine.
And I'm going to put in an oral airway in here. See if we can get a little bit better. All right, let's put this oral airway in. Let's go ahead and bag him here. Responsive. It looks like he's going to need to be intubated. Do we have our intubation stuff ready?
Everything's right behind you, ready to go.
All right, can you bag him here while I grab that?
I got it.
Can you come off for a second? Let me just take a look here. Looks like we got a little bit of blood in there. Let me suck that out. All right.
Suction.
Suction. All right, good. Great. All right, let me just take a peek here.
Let me know if you want some cricoid, Dr. Boyd.
Yeah, a little cricoid pressure would be great, thank you. All right. See his cords, tubes going in. Great.
Good color change. Good
Right.
color change.
All right, let's get him hooked up to a ventilator. In the meantime, let's put the C-spine collar back on, protect the C-spine. All right, and let me take a listen to his lungs. Betsy, there's a little bit of bleeding there. Put some pressure on that if you would.
Can we call for respiratory and a ventilator, please?
I got good breath sounds on both sides, a little bit less on the left and the right. He's got some bruising on his left chest. So let's see what we got. His airway is taken. We've got him as intubated. His pulse ox has come up to 96%. What are our vital signs doing?
Looks like his heart rate's 115 and his blood pressure is 90/42.
All right. So it looks like he's a little bit in shock. We've got airway and breathing taken care of. Is he bleeding anywhere actively? So he's bleeding down here on the leg. Can we get some more help? Hey, Will, can you help us?
Yep, come on.
Dr. Boyer, would you like a second IV?
Yes, let's start a second large bore IV, and let's hang normal saline. And how much IV is go fluid? Put some pressure on that if you would, please.
Yep.
You keep bagging. Start a second IV over here, Tracy, if you would. And I think this guy's going to need some blood, so let's call the blood bank and get a massive transfusion protocol going.
Okay.
All right. So we got control of the bleeding there, control of the bleeding there. Let me feel his pulses down here. I think his traction splint seems to be working. He's got good pulses here with some bleeding there. It looks like an open femur fracture. I don't see any obvious bleeding on his chest. His abdomen is soft. His pelvis is not stable. I think he's got a pelvic fracture, so you could have significant bleeding from there. So definitely this guy's going to need some blood, so let's make sure we get some blood products for him. In the meantime, let's expose the patient. Does that bleeding seem to be taken care of there? Did you wrap that, Will?
Yep, looks pretty good now.
All right, can you go ahead and get him exposed, take off the rest of his clothes there?
Got it.
And once we get him exposed, let's make sure we get some warm blankets to cover him back up so we don't get hypothermic. Let's do a disability exam. All right, sir, can you open your eyes?
Blood is running.
He opens his eyes to pain, that's a 2. Wasn't verbalizing, so that was a 1. Let me see if he responds to painful stimuli. Well, he's localizing, so that's a 4. That looks like he's got a significant head injury, and we're going to need to get him to a neurosurgeon. In the meantime, let's keep oxygenating him. What's his blood pressure doing now? Looks like, let's see, it's up to 105 systolic. Heart rate's down to 100. We also, I think we're going to need to wrap this pelvis with a sheet. Can you grab a sheet for me there, Will? Let's go ahead and make sure we wrap this pelvis. And we're going to need to log roll him. So we got him hooked to a ventilator.
Coming up.
All right, this is going to be on your count. You count it down for us on the count of 3.
Secure 1, 2, and 3.
All right, let me get this backboard out.
What's your IV?
And I'm going to examine the spine here to make sure there's no step off. Feels like there's no step off here. Let's do a rectal exam. I need some jelly for that. All right. All right. He's got good rectal tone. Well, I got him up here on the side. Let's put the x-ray plates in to get a chest and a pelvic x-ray.
Watch the IV, sir.
All right. And let's bring it back on your count again.
Ready? 1, 2, and 3. And 1 more.
Can we call for x-ray, please? All right, we'd like a chest and a pelvis.
Yes, sir.
All right, guys, let's reassess what we've done so far. We've done our ABCs. We've got him control his airway control. We've assessed his breathing. He's got good breath sounds, a little bit diminishment on the left-hand side. We know that he has a pelvic fracture and some bleeding from an open femur fracture. We've reduced that. We've got good pulses. He's also got some bleeding from his scalp and an obvious head injury. So this guy, clearly, we need to transfer him to a trauma center. So what I'd like to do at this juncture is we'll take a look at those x-rays we shot. I want you to put an OG tube in because of concern for a head injury, and I want you to put a Foley catheter in a moment here. And then what we'll do is reassess the patient. What are his vital signs right now?
Currently, his O2 sat is 96%. His blood pressure is 110/64. Heart rate is 97.
And we've given him how much fluids?
500 cc's of saline and 2 units of Paxil.
2 units of Paxil and 500 cc's of saline. So it sounds like we've stabilized him a little bit. We've got a sheet around his pelvis here. We're going to get him packaged up for the trauma center. So Betsy, could you get the trauma center on the phone for me? I need to talk to them and arrange transport. And while we're doing that, we're going to do a detailed secondary survey. We're going to do a head-to-toe, fingers and tubes in every orifice exam. We'll get him all packaged up to go. And also, Betsy, could you make sure that the X-ray department makes copies of all of our X-rays so we can send them along? Tracy, it looks like we've got our X-rays back. We got a chest here. Looks like he's got some rib fractures here on the left side and some haziness. He's probably got a pulmonary contusion. And his pelvic film, he's got an acetabular fracture, a pelvic fracture. That confirms, I think, what we think is going on with his blood loss. Let's get copies of these X-rays made and send them so we can send them on to the next hospital with him. Okay? Dr. Brazell, hi. This is Mark Boyer from Mary Washington. I got a patient that I need to transfer you to you. It's a 18-year-old young male who was involved in a high-speed motor vehicle collision. He ran his car off the road into a tree. There was significant damage to the front end of the car. He was unrestrained. Apparently, he was unresponsive at the scene. We intubated him. He does have some diminished breath sounds on the left side with some rib fractures, and he's also got what appears to be a pulmonary contusion. He's also got bleeding from a scalp wound. He's got an open femur fracture on the left side. We've immobilized it. He's also got a pelvic fracture. We've got him in a pelvic sling right now. We've given him 2 liters of fluid. He's got 2 units of blood. His blood pressure right now is 110/50. His heart rate is 110. And we've got him intubated on 100% oxygen with 98% saturation. Yeah, I think that he probably needs to come by air. So if we can make the arrangements to send the helicopter, I'd appreciate it. And I will package him up. I'll send some blood products and send the x-rays as well. And we'll await your arrival. In the meantime, I'll get some x-rays of his femur and everything else, but we won't delay his transport. Any other questions? No? Thanks. Thank you very much.
So this is all about primary survey and in advanced trauma life support. So if you have any questions, I would love to answer your questions. So thank you very much in listening this lecture.